all have a seat. We've got plenty of time for a panel discussion. Tony.
I think mine's probably a fairly simple one. This is probably mainly aimed at Peter. Women have more than one baby. Are they going to get vaccinated again in the next pregnancy like we do with the pertussis?
Look, there's no data that actually supports that recommendation, but I think given what we know about RSV vaccines, it may be different to pertussis, which, we give pertussis vaccines every 5 years to non-pregnant people, we give it every 2 years. I imagine that's going to be the optimal way of protecting mums, but there's probably some more research that needs to be done there, I think.
My question's simple too. Mike, it might be worthwhile just saying that the grade 3 for AS01E is much less than half of that of AS01B in terms of side effects.
Yeah, I think it was a wise decision to use less adjuvant. I'm not sure what the rationale was, but it certainly seems to have reduced severe, was what you mean by grade 3, local and systemic adverse reactions. And there was almost no potentially immune-mediated adverse reactions. But again, you probably need 1 million people to be vaccinated before you can say that with confidence. So yes, the patient will get a sore arm, 60%, but probably not as sore as they get with Shingrix. Thank you, Tony.
Thanks very much. Michael, I just wanted to ask you about your thoughts on the post-licensure Guillain-Barré data out of the US.
Yeah, no, there has been some cases, absolutely. Watch this space. I don't think it should be a game changer, but watch this space. Do you want to make some comments about it yourself?
Just at the October ACIP meeting, they showed, using a self-controlled case series approach, the FDA presented that it looked like there was a similar association with Guillain-Barré in both vaccines, roughly similar extent, that the attributable risk was thought to be less than 10 cases per million doses.
Yeah, 10 per million is up there, isn't it? Because it was 1 per million with flu vaccination, so that's a significant number. I don't think it'll kill the vaccine, but it's certainly something to be aware of and something we need to eventually have a discussion with our patients about. Thank you for bringing that up.
Shingrix was 3 per million after each dose.
So 3 per million with Shingrix. Thanks, Tony.
Ian.
An easy question for you, Peter, and then maybe a more difficult one. If you get low coverage rates with the maternal vaccine, is there enough nirsevimab on order or in the fridges to do anything useful? And secondly, your comment on the adverse events with the mRNA vaccine, which was targeted towards pre-F protein in young children or 5 to 7 month old children.
So first question is the easy one. I think it depends on how low the coverage is. If coverage is 50% for maternal, 50 to 60%, then I think there's probably enough. But if it's less than that, then we'll have to ask for some more nirsevimab if that's the case. And that's why, to be honest, I think we need to have more information out about what we're doing and how we're doing it as soon as possible so that we do get that coverage up. But I think that is a risk this year in particular. But all states have ordered a significant amount, just whether they've ordered enough is the question. So I think WA has.
The rich state.
Yeah, it's all that iron ore pays for everything. Look, the issue, I think that's the finding with the mRNA vaccine. We were actually going to be involved in that study till we rolled out the nirsevimab program because it was in infants 6 to 8 months of age, so seronegative infants. And for those who aren't aware of it, there was no evidence of protective efficacy in looking at this small study in infants, mostly in Panama actually, where the vaccination program started during the season, so not all of them had 2 doses. But there was no evidence of protection. You're just as likely to get RSV in the vaccine group as in the control group. And in fact, some of those children were hospitalised and I think one was in ICU. But the numbers are literally a handful of figures. And there was 3 groups. So there was RSV only, RSV plus HMPV and control. So, but what it has meant is that there's now a hold on all studies with RSV vaccines in seronegative children, which means basically anyone under 2, I think you can't assume that they would be seropositive under that age. But there is a live attenuated RSV vaccine that's temporarily halted, but I think is going to be restarting. That will be for toddlers, so the idea is that's the vaccine after you've had your maternal vaccination and or monoclonal antibody, because that's a different mechanism. But the thing that I really was puzzling about that is that where they looked, the children the infants who'd received the RSV vaccine actually got good neutralising titers. So I don't think it was quite the same as what happened 60 years ago, but it really, I'm not quite sure. And there may be some issues about how those were measured, but I certainly think it's has really halted that sort of ability for us to fill that under 5 gap with RSV vaccine. So we'll have to watch this space, I think.
But the mRNA vaccine for those over 60, the Moderna one, certainly we have season 1 and season 2 data. It looks not bad. The season 2 data was potentially a bit disappointing. There's no evidence that I'm aware of that the mRNA vaccine in older people causes more severe RSV if you happen to get it and hospitalised.
Yeah, and I think Moderna have also done studies on older kids who are seropositive, and they didn't have that problem. There's one tricky question, although it's an unusual event, about one of the problems of the hybrid program is that you might give the wrong vaccine. So apparently there's already been a 6-month-old child who's got has got Abrysvo instead of Nirsevimab. Can you give the infant Nirsevimab? Well, the infant's probably not protected because they'll be seronegative and you need at least 2 doses to get adequate protection. And the good thing about a monoclonal antibody is it doesn't really depend on having a previous vaccine. So yes, you can give it to that person. And maybe some GP education is needed somewhere.
Yeah, thank you. As a GP, thank you very much. Look forward to it. Jeremy Farrar talked to us about we've got to have the community on board, we've got to have the politicians on board. My sense is that pregnancy and kids seems to have parents on board, and then the politicians probably, but Michael, have we got adults and elderly population on board for the RSV vaccine? So there's a community on board and are the politicians going to be ready to back that up?
Look, it's amazing, isn't it, how good the uptake of Shingrix and even before that Zostavax was. I mean, they were really good uptakes for vaccines against what essentially are non-fatal diseases, although can be very significantly associated with morbidity and loss of independence. I don't see any reason why we can't get the same sort of interest in RSV on the background of the general RSV hesitancy, apathy that we're seeing post-COVID. That's another long story. I'm pretty confident that we'll get good uptakes. I hear from GSK that the uptake of RSV as a private script has actually been quite good, within or above expectations. So I think we certainly need public campaigns. We need awareness campaigns, as we've had with Shingrix, as we've had with other respiratory vaccines. But I don't have any concerns about RSV being disregarded by older people.
I think with politicians, it'd be nice if you could say that 30% reduction in future mortality or cardiac events will keep the hospitals less full, and so no ambulance ramping equals politicians buy into it.
That's a very good approach. Of course, anecdote is the rule of anecdote is policy, and we just need 1 or 2 older politicians to get nasty RSV. And believe it or not, that worked with Shingrix. I with Zostavax, I walked around Parliament House and cannot tell you how many of the ministers I happened to speak to that day had a personal anecdote, and then very soon afterwards, Zostavax was listed.
And there is an election coming up.
There's a question online. If we reduce the burden in children, will we see a benefit in adults?
No, this is not a vaccine that will induce herd immunity. Nirsevimab specifically targets the lungs, and so it doesn't actually stop the children getting upper respiratory infections completely, and actually that's probably a good thing because it means they're primed when they see RSV the following season, that they actually can get a rise in their antibodies. So no, and also it's the toddlers in daycare that we've got to stop transmission in, I think, for RSV. So until we have a vaccine for that age group, I don't think we're going to get herd effects, unfortunately.
The question that hasn't been asked is how often will the adult one have to be given? And I've given you 3-year data. We just can't say. It's neither the Pfizer or the GSK studies are going to go beyond those 3 and 2 years respectively, the other way around. My suspicion, and this is purely my bones talking rather than anything driven by data, is that RSV will be given every 5 years. That's my suspicion.
Good. One last.
A question for Peter. With at the opposite end of the anecdotal responsive politician is the health economist. And given we have a federally administered maternal vaccine program with a jurisdictionally administered nirsevimab programs, what do you think the impact on cost effectiveness is likely to be, given we assume many children will either inadvertently or deliberately have both protection?
So Jim, I think you saw the back of the envelope stuff from the prevented hospitalisations almost paid for the nirsevimab program. So assuming that the maternal RSV vaccine is slightly cheaper, which is why we can give it all year round, I think having a few double dosings probably not going to sort of blow the bank budget, but I think it's really important, and I think we really need to have good studies that can address prospectively the impact and effectiveness of these programs, because I think that's how you keep politicians on board with programs, is actually you demonstrate it's going to be saving you money overall. And certainly I think if you add in all the GP visits that occur, let alone time off work caring for sick children and children off daycare, I think you'll find that these programs, because it's so frequent, I think it's 1 in 10 needed to immunise to prevent one GP visit with nirsevimab. So I think given what's happening in general practice, more broadly in access issues, I think, as well as ED, emergency department issues, which weren't included in that data, I think it's very likely to be a cost-effective program, and we just need to make the best of it, is all I put a plea out there to all the states.
And some outcomes surprise us. I don't think, to be honest, even GSK thought that Shingrix would get the NIP listing to 65. I think they were expecting 70. So sometimes the decisions are very favourable in terms of coverage. So keep our fingers crossed and keep hopeful and keep lobbying.
A great note to end on. We can thank both Peter and Michael.